Hello and welcome to another episode of Conversations with Dr. Westman. Today we're going to be chatting about Dr. Westman's probably one of his favorite topics, which is insulin. We also have a fantastic bonus for you. It's Dr. Westman's free top 10 fat loss tips. We'll put that link for you in the description, so be sure to go check it out and grab that top 10 fat loss tips by Dr. Westman. How are you, Eric?
Doing well. How are you, Glenn?
Very good, thank you. So, Eric, help us, give us your interpretation of what the main role of insulin in our bodies is.
Yeah. So, of course, my approach is to try to keep things simple, try not to overcomplicate things. And from a clinical practice of internal medicine, now obesity medicine and keto medicine, insulin, it's actually pretty complicated. It's hard to boil it down to just one thing. Although I think in the big picture view, you'd want to think of insulin as something that's essential for type 1 diabetes, meaning as a drug. Otherwise, it's something you don't want much of. So even shots that you give of insulin for type 2 diabetes or shots your body gives you, secretion your body gives you in response to having sugar and starches, because those get digested to sugar. So insulin itself, let's avoid type 1 diabetes because it's essential to have an injection. So if we're not talking about type 1 diabetes, that's where you don't make any insulin at all and you need injections. Let's talk about just people in general and then type 2 diabetes. You don't want much insulin inside your body all day long. You want it to have episodes of going up or maybe even not much at all. It turns out insulin is a growth hormone. And that's really what I want you to think of. It promotes growth of muscles, it promotes growth of fat cells, it promotes growth of cancers. So because it's in that growth hormone sort of category, it also means that it's pro-inflammation, because inflammation is part of this whole category of chemicals that you need to repair. So did you know when you work out at the gym and you get sore, actually that's inflammation. That's the soreness that's coming in, the inflammation to repair things and to make it stronger. So there are even times when you're trying to get that kind of inflammatory response, but generally speaking, you don't want insulin around to push your body toward excessive growth, especially fat cell growth and inflammation.
Now, you often hear the term insulin resistance and insulin sensitivity. What is the difference?
Well, now, did you notice when I described insulin, I didn't measure or mention blood sugars? That it is a hormone that can lower blood sugars, and that's what I have been trained in, how great insulin is, isn't it wonderful? And all. Well, it really isn't designed to do that. So, I mean, how do I know this? Well, it's something that we in the keto community have looked at and talked about for a long time. Meaning, if you weren't eating much sugar and starch at all, you wouldn't need much insulin around at all. But you do need some insulin to help growth in the muscle cells. So most of us kind of have the idea that, the idea of insulin to lower blood sugar, that's really not what it's supposed to do, but our bodies use it for that. And that's where insulin resistance comes in, because your body doesn't want all that sugar going into the cells, and insulin helps the sugar into the cells. So basically it turns down the volume, so to speak, or the effect of the insulin. And that's what insulin resistance is called, when really it's just a normal response to having too much sugar around. So I know, again, I'm internal medicine, obesity medicine, keto medicine trained, and we were all trained that there's some abnormality in the middle of the cell that causes the insulin resistance, and it sends out signals to the cell wall. But that's in response to having too much glucose coming into the cell. So you look at it from another perspective, insulin resistance is a form of carbohydrate intolerance, meaning your cells are trying to keep the sugar out of the cell, meaning turning down the ability of insulin to bring it in. So the medical model, internal medicine endocrinology model, is to just give more insulin when insulin doesn't work well. And then, of course, from the cell's perspective, it just dials down so you give more and more insulin. Did you know that there are now such concentrated amounts of insulin in a vial? It used to be you could only get what's called U100, meaning there's 100 units per ml. Now it's U500. In fact, they're trying to make even more concentrated insulin so that you could just keep pushing the insulin in the cell. When the problem, pushing glucose and insulin in the cell, but the problem is there's too much glucose already. So let me explain it a different way. When people were examined with elevated blood sugars, but they had type 2 diabetes, the insulin in the blood was already high. Remember, this is not type 1 diabetes where they don't have insulin at all. They need insulin. Generally, that's in childhood, but some adults have type 1 now. Type 2, they had high blood sugars, but their insulin was already too high. So this is where the idea of insulin resistance came out, where, well, if the blood sugar is too high and you have lots of insulin, it must be the insulin doesn't work right, and that's the abnormality. So we'll just give more insulin and more, without thinking that maybe the problem is there's too much sugar around in the first place. So this is where obesity medicine and keto medicine breaks from traditional endocrinology and traditional internal medicine. And remember, I'm at Duke University. I'm past president of the Obesity Medicine Association. I've been in the mainstream medical community for my entire career, 30 years at Duke. I don't say this lightly. In fact, it's taken me 15 years of using this kind of approach to speak with the confidence that I do, even though I know there are other doctors who don't understand this and speak against what we're saying. So, so insulin's already high if you have type 2 diabetes. I think the last thing you want to do is to take an insulin shot for type 2 diabetes, which then makes you gain weight and then puts you on the path so that you will always have type 2 diabetes now. So now I'm at this kind of conflict point of, my patients come to me, my doctor says I have diabetes and they want to put me on insulin, and I'm overweight or obese, and they understand that maybe there's another way. So I just explained that if I can help you lose the weight, change the lifestyle, or do some sort of approach, you don't need to go on the insulin. So that's often the point at which some people come to me for help, because they don't want to go on the insulin shots. They know that their family member went on insulin and then they didn't really have a good outcome. So this would all be great if insulin fixed everything, but it really doesn't. So why are we talking? So if you don't really need insulin because of type 1 diabetes, you don't want to have much insulin around.
Now, what about insulin sensitivity?
Right. So insulin resistance and insulin sensitivity are really the same name, the same thing. So that just calling it from a different perspective. So to increase your insulin sensitivity, actually you want to reduce the glucose going into your bloodstream. So and lose weight. So it turns out the abdominal obesity, if you have extra weight, actually causes and contributes to the insulin resistance, meaning not insulin sensitivity, but lower insulin sensitivity. So, it all comes together into the low carb keto world, because there's really no better diet and better lifestyle approach to lower the insulin levels than to take sugar and starch out of the food. So really on a keto diet, you're eating foods that don't raise the blood glucose and don't raise the insulin levels, and that helps the insulin sensitivity improve or the insulin resistance reduce.
Now, a lot of the times, Eric, a doctor will check your hemoglobin A1C or HbA1c before they check fasting insulin. And isn't it true that fasting insulin can tell us a lot about where a patient is headed before they even have an elevated A1C?
Yeah, so you don't want to wait. Well, the reality today is many people come to me already on insulin and already on these other medications for diabetes, and I get to help them get off them. I would rather have you think about this before you get down that pathway further. So if, let's say, you're otherwise healthy, it turns out that, and you have normal weight, it turns out that's not going to give you the best indication of your tendency toward diabetes and toward the unhealthy metabolic state. So measuring a fasting glucose and fasting insulin, and even your response to a sugar load to see how far the blood sugar and the insulin goes up, are all important indicators that your metabolism is going down that pathway toward diabetes, type 2 diabetes. So you can get early indicators that you're susceptible for that. And that's important to do if you're worried about long-term health and let's say you need to be convinced that, well, why do I need to restrict carbohydrates? Why do I need to not eat sugar? Well, you get the fasting sugar or the A1C, your fasting insulin even can be very helpful. And if those are elevated, it means that you're going to do better with less carbohydrate, less sugar and starch in the food that you're eating. So, the whole medical field is shifting from avoiding food that has fat to avoiding food and drinks that have sugar. This is kind of the big view, general trend.
Now, is there a range that people can look out for in terms of what is a normal range for a fasting? What the fasting insulin should be? Is there a range after that you would be concerned with?
Right. So you can actually look up a range on in milligrams per deciliter or millimole, depending on where you live. We use milligrams per deciliter in the U.S., and anything under 100 is going to be normal. The interesting thing is that the blood sugar level itself doesn't tell you how much insulin it takes to keep the blood sugar down. So even after a meal, say you eat a big apple and the blood sugar goes up a little, if you have a big insulin response, it keeps the blood sugar down. If all you did is check the sugar, you're not going to know that you had this big insulin response. And we think that response of insulin is not good. That means you're going down that insulin resistance pathway. So you want to have some kind of evaluation that includes a blood glucose and a blood insulin level at the same time. If you're not sure you're going to do this, you see that if someone comes to me to do a keto diet, I don't really need to do all these tests because I know it's going to get better on a keto diet. But if you're not sure, or you need to be persuaded that your metabolism needs something like this, these are useful tests: the A1C, the glucose, the insulin levels.
Now, tell me, Eric, for people that are not following a keto diet, so this is someone that's eating 300 to 500 grams of carbs a day, would you say that type 2 diabetes and obesity are progressive conditions for these type of people that are not on a keto diet?
Well, right. So this is where the confusion, and one of the sources of confusion is that what doctors see most of the time, and they'll say diabetes is a chronic progression. Well, that's only if you're, eating a bad diet and having a bad lifestyle that's causing the diabetes itself. So it's kind of like saying, you can never cure this infectious disease because you always have the infection around. Well, that's true. So let's take you away from the place where the infection is and you treat the infection, you don't have it again. So now the contributors to diabetes and why doctors, endocrinologists will say you will always have diabetes, that's because they assume you're always going to be eating the very high carb, high sugar sort of diet that caused the diabetes in the first place. I hope we get to a day where the doctor will at least give you a choice. They say, well, it looks like the diabetes is getting worse and I need to put you on this pill. Or you could, talk to that lifestyle guy down the street. And the problem is most doctors assume that it's hard to do. They haven't been taught how to teach people. And we've been teaching doctors to just use medicines. But a growing number of doctors are seeing that the lifestyle approach however you do it. I mean, it doesn't have to be keto. Just taking the carbs down and getting the sugar out can be so helpful for so many people.
So, Eric, your simple non-surgical solution of sticking to no more than 20 grams total carbs per day will eliminate sugar spikes and therefore insulin spikes, correct?
That's right. That's right.
Okay. So let's move on to a couple of questions. I have a question here from Jess, and Jess asks, I'm currently insulin resistant. If I start your program, is it possible to eventually become insulin sensitive again?
Yes. Yes. And there's a timing that's important to know. It may not happen overnight. So when you do a keto diet, there are two things that are happening. One is you're taking away the food and drink contribution to the blood sugar and insulin on the first day. So there's a big effect. In fact, I have to reduce people's insulin on the first day. It can be dangerous if they're taking all the insulin to cover the carbs, and then you cut the carbs without the insulin being reduced. They can have low blood sugar spells. So the second thing that happens on a keto diet is that the weight comes off, the extra fat weight, and that contributes to insulin resistance as well. So, in my practice, most people will have immediate improvements, but I still have some people who a few years into it, because they started in, 400 pounds, at 200 kgs, that they still have insulin resistance, but they've made great improvements in it. So it kind of depends where you are and severity, how fast it will improve.
Now, Katrin asks, your method you use to treat folks with type 2, for type 2 diabetes, is it a cure or a remission?
Well, this is really a semantic. I mean, meaning it's just how you want to phrase it. In the US at the moment, if you say something is cured, you come under the scrutiny of the federal regulators. And there are a lot of people who use the word cure inappropriately. A lot of people trying to bilk you of money and especially in the cancer world. But diabetes, a cure of diabetes is defined as having normal blood sugars, no evidence of diabetes for 5 years. And that's in a standard article in the medical literature. You can say in remission or reversed, and it doesn't come under those same scrutiny. And so what we like to say is that you can reverse the diabetes, meaning you get off the insulin, your blood sugars are normalized, and you have no evidence of diabetes, and that's a reversal. When that's maintained for 5 years, yes, that's a cure. And the interesting thing is most other doctors who don't use these approaches have no idea that you can cure diabetes. They don't know how to do it. They feel like they need to follow guidelines that push you toward medications like insulin. So that's kind of the conundrum that we're in.
So I have a final question from Tia, and she asks, what is your success rate for reversing obesity and type 2 diabetes in your clinic?
Well, it's a hard number to get at, the success rate. Pretty much if you do it and it you follow it, it's almost 100%. So when you look at the success rates, you're also looking at how well people follow it. So if you put people on a metabolic ward, and these studies were done back in the mid 2004, 2005, it works for everyone because you're in a metabolic ward and you make people do it. They have no choice. You come to a residential program like in Durham, there are several residential programs where you can move and stay here. And if you follow it, it works 100%. So the problem is getting people to be able to do it in their real world, real life. And so in a clinic where people come to me from all over various stages of disease, it's not 100% because people can't follow it 100% at home when they have all of the distractions and holidays and things like that. But so how do I turn that around? I basically say, this is like a pill. The pill has been studied and it works, and it would be FDA approved if there were a process for it. So if you follow it, it will work. but I can't make you swallow the pill. I can't, if it's too large, if it's, so you have to separate out, yes, it works, but can everyone, I'm not perfect in getting everyone to be able to follow it. And this is where support groups and even addiction kind of groups are really helpful to get people started, and then they see the results. And it's pretty amazing how effective it can be.
Well, Eric, thank you so much for discussing this very, very important topic with us today. We really do appreciate all this information that you give us on a week-to-week basis. That's all for us today, folks. Don't forget to get Dr. Westman's free top 10 fat loss tips. The link will be in the description. And if you would like to learn more about Adapt Your Life Academy, upcoming online courses, you can find us at adaptyourlifeacademy.com. If you enjoyed this video, you can find us at YouTube, Facebook, Instagram, and Twitter. This is Eric and Glenn signing off of another episode of Conversations with Dr. Westman. Eric, once again, thank you so much for your time. Until next week, thank you so much.
If you like this video, you're going to love our Adapt Your Life Academy. So click on the link in the description to find out more.